We'll sit down once we get started.
We're hot.
I'll introduce you. Yeah, why don't you go away? Stay here. Stay here. All right. I don't know if I need the mic. Why don't we go ahead and get started? Sipowitz. Why don't we go ahead and get started? Can you hear me in the back row? Yes? How do we get classrooms to quiet down? All right. Okay, everybody, thank you for coming today. I am Mary Ramos. I'm very pleased to announce our speaker this afternoon, Rachel Sebastian. Rachel is from the greater Cincinnati area. However, she's partnered for several years now with both the New Mexico Department of Health and UNM Pediatrics in Vision, New Mexico, on a variety of research projects involving school-based health centers, adolescent health, school health. Her talk this afternoon is Adolescent Substance Use and Quality of Care.
Thanks. Okay. Thank you all for being here. I'm very grateful to have this opportunity to share some of my work with you all. I'm not a very loud talker. It's kind of a big room, so I'm going to go ahead and use this microphone. Unfortunately, I have to hold it right here. It doesn't work down. It's got to be here, so it feels kind of awkward, but for your benefit, I'm going to go ahead and do that. So my purpose today is to present some findings around adolescent self-reports of substance use and measures of their healthcare quality. I'm going to give you a little bit of background first, just so you have some context for these findings. In 2015, the New Mexico Department of Health partnered with the University of New Mexico's Center on Alcoholism, Substance Abuse, and Addictions, or CASA, along with Envision New Mexico, which is housed within the UNM Department of Pediatrics, to start a project that was funded by the Hilton Foundation to implement SBIRT, or Screening, Brief Intervention, and Referral to Treatment, in as many New Mexico school-based health centers as they could over the course of a 3-year project. So SBIRT is an approach to addressing substance use. It's been endorsed by several professional bodies, and it involves implementing universal screening, first of all, so that providers know when adolescents might have a substance use problem. And then it involves ensuring that providers are prepared, that they're able to perform a brief intervention if necessary, or even a referral to specialty treatment for adolescents that they think might have a substance use problem. So to complement the evaluation of this project, we collaborated with the Department of Health to include some additional measures in their annual school-based health center satisfaction survey. So all school-based health centers that are supported by the Department of Health are required every year to do a survey of their patients. In the past, the survey has included measures of their healthcare utilization to get a sense of what school-based health center services they're accessing, as well as services that they're receiving at other types of places. And then, of course, their satisfaction with the care that they're receiving at school-based health centers, as well as at other places, and then some demographic measures. So knowing that the department would be doing this survey on a yearly basis anyway, we saw this as an opportunity to add another dimension to the evaluation of this project, where we could get the perspective of adolescents and collect some data on how they see their healthcare quality, and in particular, some specifics around the care that they're receiving around substance use. So to this survey that they already were conducting every year, we added measures of their past 30-day substance use, measures on depression and school failure risk, measures of their receipt of patient-centered care, and measures of their receipt of anticipatory guidance. So like I said, the purpose of this analysis was to look specifically at how, or at the relationship between their reports of substance use and measures of their quality of care, and in particular, their receipt of anticipatory guidance. I'm going to spend just a few minutes talking about some of those measures that we added to the survey so that you can better understand the findings when I show you those. So given that this project focused on substance use, we obviously wanted to know about students' recent substance use. So we included in the survey a question asking if they had used any of 8 specific substances, or really substance groups, within the past 30 days. And these included tobacco, alcohol, marijuana, inhalants, prescription drugs to get high, heroin or other opiates, cocaine, crack or methamphetamines, or any other drugs. And we wanted to be able to compare students who used substances with those who didn't. But we also wanted to be able to compare and see if there were notable differences by the types of substances that they were using. So for analysis purposes, we categorized this into, first of all, any substance use or no substance use. So students who used at least one of the listed substances. And then we categorized them into those who used at least one illegal or illicit substance and those who did not, with or without other substance use. And then we further categorized this to pull out those kids who were using what we considered high-risk substances. So these included things like cocaine, crack, methamphetamines, prescription drugs, and heroin or other opiates. The kids who said that they had used those with or without any other substances were pulled into this category. So these are not mutually exclusive. There's overlap between these categories. But the purpose, again, was to be able to see if there's differences based on the types of substances that they're reporting using. For depression and school failure risk, it was pretty straightforward. We added one item to the survey asking if during the last 12 months they ever felt so sad or depressed or hopeless for 2 weeks or more in a row that they stopped doing some of their usual activities. It's just a yes/no question. And then as far as their grades, we asked them to report on their last report card if they had mostly A's, B's, C's, D's, or F's. And then students who reported that they had mostly D's or F's on their last report card are considered to be at risk for school failure. We also included a measure of the receipt of patient-centered care. So this item that we included in the survey, it's a validated scale. It comes from the CAPS surveys. It's the Consumer Assessment of Healthcare Providers and Systems. So it's pretty widely used. And we included these 4 items that asked students how often in the past year their school-based health center providers listened carefully to them, explained things in a way they could understand, showed respect for what they had to say, and spent enough time with them. And the response categories were never, sometimes, usually, or always. And finally, to measure the receipt of anticipatory guidance, we adapted this needs-based anticipatory guidance measurement model from the Youth Engagement with Health Services survey. So this survey, also known as the YES, is something that we had developed as part of a previous project with school-based health centers. It was developed during a CHIPR quality improvement demonstration grant with school-based health centers in New Mexico and Colorado. And the unique thing about this measurement of anticipatory guidance is that it assesses not just whether or not they received guidance, the recommended guidance, on these various topics, but it allows them to respond in a way so that we know whether or not their needs for guidance were met, or whether, conversely, they had unmet needs for guidance. So this example here is from the YES survey, just to show you how it's laid out with the anticipatory guidance topics, and then their full response options. So they can answer with yes, and I got what I needed. Yes, but I did not get what I needed. No, but I needed to talk about that. Or no, but I did not need to talk about that. And then these were the specific topic areas of anticipatory guidance that we included in the satisfaction survey. These are adapted from the behavioral health domains of anticipatory guidance from the AAP's Bright Futures Guidelines. So for social and academic competence, we asked if providers had discussed with them things about their family, their friends, their school performance or grades. For emotional well-being, we asked if providers had discussed with them their emotions or moods, suicide, how they deal with stress, and of course substance use, if they had talked about tobacco use, alcohol use, illegal drug use, and how to support their friends in themselves and not using drugs. we're analyzing the responses to these, to the needs-based response categories, it allows us to know a few different things. Again, it doesn't just measure whether or not they received guidance, although that's one of the things we can see by looking at either of the yes options. Did they get the guidance on that topic or not? But further, we can see whether or not the guidance that they received met their needs. So if they answered yes and I got what I needed for that topic, we know that their needs were met. And then even further, it allows us to see if kids are leaving the clinic with unmet needs for guidance. So if they answered with either yes, but I did not get what I needed, or no, but I needed to talk about that, then we consider them to have an unmet need for guidance for that topic. So like I said, the survey is done every year. In 2015, it was done from April to the end of May. And it's done in the school-based health centers. It's administered by the school-based health center staff. Most of them administer it on an iPad, but some of them at that time were using a paper-based survey. And the way it worked is that if students came in during the time that it was being administered for services, they were just asked if they wanted to complete the survey. It wasn't mandatory, and it was anonymous. So table 1 here shows an overview of the demographic characteristics, the risk factors, and the healthcare utilization patterns of the students who responded to the survey in 2015. There were a total of 1,233 that responded. They were about 15 and a half years of age. The majority of them were female and Hispanic. About 14% identified as lesbian, gay, bisexual, or questioning. And about a third indicated that they were at risk for depression. About 8.8% were at risk for school failure. Almost 30% indicated that they had used at least one substance within the past 30 days. In terms of their healthcare utilization, over half of them were usual school-based health center users. This means that they reported that they had more visits to the school-based health center in the past year than to any other place for care in the past year. Over half of them had received a checkup in the past year. Almost 40% had received behavioral health care. And then about a quarter had received sexual or reproductive health care within the past year. So looking a little deeper into their substance use patterns, Table 2 shows the substance use patterns of the respondents in the past 30 days, including the specific substances that we asked about in the survey. So again, almost 30% said that they had used at least one substance within the past 30 days. About 12% used just one substance, 16.6% used 2 or more. Looking at the specific substances used, marijuana was the most common, with almost 20% reporting using marijuana during the past 30 days, which was followed by alcohol and then tobacco. And I should point out this is actually a really common trend that we're seeing now, substance use patterns, that marijuana is more commonly used than alcohol. And then by type of substance use, 21.7% reported using illicit or illegal substances during the past 30 days, and nearly 5% reported using what we had called high-risk substances. So remember, those were cocaine, crack, methamphetamines, heroin, and opiates, and prescription drugs. So we wanted to see if there were differences among these students who were in these different types of substance use categories from their peers in terms of their demographic characteristics and other risk factors. So that's what we see here in Table 3. So first of all, we can see that age was associated with substance use, such that kids who were older were more likely to use any substances and were more likely to use illicit substances or illegal substances. Sexual orientation was associated with substance use as well, such that kids who reported using any substances, kids who reported using illicit substances, and who reported using high-risk substances were all more likely to identify as lesbian, gay, bisexual, or transgender. And we also saw differences by race and ethnicity. So kids who reported any substance use and who reported illicit substance use were less likely to be white, but kids reporting all kinds of substance use were far more likely to be American Indian or Native American. And then, not surprisingly, we see that substance use is associated with these other risks, like depression and school failure, by quite a lot. Really. Kids who are reporting any kind of substance use were far more likely to indicate that they were at risk of depression and far more likely to indicate that they were at risk of school failure. In terms of their receipt of patient-centered care, what this table shows is for each of those categories of substance use, the percentage of students who reported that their school-based health center provider usually or always did those following things that are considered to be components of patient-centered care. And then it also goes in mean scale score for those 4 items. So the one thing that we see for students reporting any substance use and reporting illicit substance use, there really aren't significant differences in terms of their receipt of patient-centered care. They're just as likely as their non-substance using peers to report that their providers listen carefully to them, explain things to them in a way they can understand, show respect for what they have to say, and spend enough time with them. And the only time we see a difference is with those kids who are reporting high-risk substance use, in which case they are less likely to say that their providers show respect for what they have to say and spend enough time with them. In terms of their receipt of anticipatory guidance, we saw many differences by type of substance use. So that's what we're seeing here for each of those categories of substance use, looking at the topic areas of anticipatory guidance. And under each of those, we look at the percentage who say that they received guidance on all the topics in that topic area, that first line under each topic area. And then the next one is the percentage who said that the guidance they received met their needs for each item in that topic area. And then finally, the percentage of unmet needs. That's when they reported having an unmet need for at least one item in that topic area. So just looking at this table, we see a couple patterns start to emerge. First of all, students who are reporting substance use are reporting that they're receiving a lot more anticipatory guidance than their peers. So they're receiving more guidance. Just as one of the examples, we see that 47% of students who reported any substance use said that they received guidance for all items in social and academic competence. 50% of those who reported illicit use said they got guidance on all these topics, and 52.9% of those reporting high-risk use. And that was compared to 37.5% of the kids who are reporting no substance use. So they're getting more guidance. We can also see that students who are reporting substance use are more likely in many cases to receive guidance that meets their needs as well. So when we're looking at this, we look at the gap between the percent who are reporting that they received guidance on all of those items and the percentage who say that they received guidance that met their needs. And when that gap is relatively small, then we know that most of the guidance that they're receiving around that topic is meeting their needs. So we see that in many cases, students who are reporting substance use are reporting receiving guidance that meets their needs. However, they are reporting far more unmet needs for guidance. So despite the fact that they're receiving more guidance from their providers than their peers, and even though that guidance is meeting their needs a lot of the times, they are still leaving with more unmet needs for guidance than their peers. In some cases, a lot more. And the percentage with at least one unmet need in any of the topic areas at all is quite high. For kids who are not using any substances, it's 17.7%. And that jumps to 32.5% and 34.6% for those using any or illicit substances, and then up to almost 45% for kids who reported using high-risk substances, so almost half of them. Nearly half of them are having an unmet need for guidance. considering, what we've learned from the bivariate analyses, kind of pulling this all together, we see that substance use is associated with certain demographic characteristics. It is associated with other risk factors, and it is associated with having unmet needs for guidance as well as receiving more guidance. But of particular concern, it's definitely associated with having more unmet needs for guidance. So to further explore this, we put this into a logistic regression model. We actually created 3 of them, one for each of the substance use categories. So this shows the odds of having an unmet need for guidance for a student who reported using any substance use. And we say that for them, they are more than twice as likely as other kids to have an unmet need for guidance. That effect diminishes somewhat when we adjust the model for these demographic characteristics that are also associated with having unmet needs for guidance. Age is negatively associated with having unmet needs for guidance, meaning that as kids get older, they're less likely to have an unmet need. We see that being white is associated with fewer unmet needs for guidance. And then we also see that these other risk factors, depression and risk of school failure, are also associated with having unmet needs for guidance and increase the likelihood of that by more than twice. But then, when we look at the effect of patient-centered care, the kids reporting that they received patient-centered care on all these different factors here, we see that has a strong and significant effect. So even in a model that includes these other variables that have a strong and positive association with having more unmet needs for guidance, receiving patient-centered care cuts that likelihood of having an unmet need for guidance in half. We saw basically the same pattern in the model with kids who used illicit substances. It was very similar. They were more than twice as likely as other students to have unmet needs for guidance. Again, this effect did diminish somewhat when we considered when we adjusted the model for these other variables, and slightly more when we included patient-centered care in the model as well. And finally, we ran the same analysis for students who reported using high-risk substances. And here, the pattern was the same. The students who reported using high-risk substances were even more likely to have an unmet need for guidance than were other kids, more than 3 times as likely as other students. So we see a big jump there. Again, this diminishes somewhat when adjusting the model for demographic and other risk factors. So they were more than twice as likely as other students to have an unmet need for guidance. And again, that patient-centered care has a strong and significant effect of diminishing the likelihood of having an unmet need for guidance. All right, so to pull all these results together, what do we do with this? We see a few different things. First of all, substance use is prevalent among adolescents who utilize school-based health centers in New Mexico. So that nearly a third of them report using at least one substance in the past 30 days. About 22% reported using illegal substances like marijuana or cocaine. And nearly 5% reported using what we consider to be high-risk substances. This isn't really surprising. We know that adolescent substance use is a major health concern in New Mexico as well as across the nation, but we know that in New Mexico our rates are even higher than the national averages. So it's not surprising. We see that substance use is not equally distributed among adolescents, that it is associated with age, with race and ethnicity, with sexual orientation, and that it's not surprisingly associated with other risk factors like depression and school failure. One very hopeful finding in all this is that students who reported using substances reported similar levels of receiving patient-centered care as their non-substance using peers. So here, remember, the exception was those students who had used high-risk substances who were less likely to say that their providers showed respect for what they had to say and spend enough time with them. But Nonetheless, given that patient-centered care appears to have a strong and significant effect on the receipt of anticipatory guidance, it's promising that most students are reporting receiving patient-centered care among this population. And then, with regards to unmet needs, we found that adolescents who report substance use of all types have both higher needs for guidance than their peers, because they're getting more guidance, they're more likely to have their needs met, and yet still they're reporting more unmet needs for guidance. So these results suggest that providers are able to see that these students who are using substances are having higher needs, that they do need more guidance. And it shows that oftentimes the guidance that they're giving them is meeting their needs. But it does point out that they're much more likely than their peers to leave the clinic, leave that office with unmet needs for guidance. So again, in other words, it's when they're reporting unmet needs, it's usually not because whatever the provider said to them didn't meet their needs. It's because something wasn't discussed at all. And then we also see that type of substance use matters. Substance use overall of any kind is associated with other risks, and it's associated with more unmet needs for guidance. But we see that students using illicit substances and high-risk substances have even more associated risks and even more unmet needs for guidance than their peers. So looking at the type of their substance use matters, in addition to just knowing which kids are and are not using substances. So just a couple more points that I want to make about what the implications of these findings are in terms of practice and in terms of policy. So first, in terms of practice, these findings highlight the importance of patient-centered care, first and foremost. When adolescents receive patient-centered care, they are less likely to leave with unmet needs for guidance. And that's the case for all kids. This is the case even in models that include the strong and significant effects of substance use and depression and school failure risk. The patient-centered care is a way to reduce unmet needs for guidance for all kids, and in particular those who have higher needs for guidance and who are at greater risk. These findings also highlight the importance of screening for substance use with a tool that is substance-specific. Knowing that substance use is associated with greater needs for guidance from providers, it's important to know when adolescents are using substances. And it's important to know what they're using, what types of substances they're using. Most screening tools, however, are not substance-specific or are only partially substance-specific. So it is really necessary that we use a screening tool universally that is specific to different types of substances. And then finally, in terms of policy, these findings highlight the necessity of having a standardized measurement tool and protocol in place for measuring the healthcare quality of adolescents specifically. So using a tool that's designed for adolescents, collecting data on their healthcare and their needs from their perspective. These findings also point to the necessity of measuring the receipt of guidance based on the needs of the adolescent. It's not just enough to know whether or not adolescents are receiving the recommended anticipatory guidance. If we didn't ask the question in this way, we wouldn't have any way of knowing that they had received guidance that met their needs, and we wouldn't know what percentages of them had unmet needs for guidance. So it's not enough just to ask whether or not they are receiving guidance. We need to be asking using some kind of a needs-based measurement model. That is all I have. Thank you for your time. I'm glad to take any questions. Yes, Jerry.
That was wonderful. So
Thank you.
Rachel.
Thank you.
I have a couple of other suggestions around policy.
Okay,
I was
great.
fascinated with the fact that, I should say, I've known Rachel for a long time. Rachel and I
Yes.
worked together when we went to Cincinnati, so I can pay her in.
Okay.
I find it really fascinating that if providers, that the unmet need was around nothing, said, rather than something being said.
Right.
wasn't enough.
Yeah.
So that speaks to the need for more guidance, more
Yes.
assertiveness on the part of providers. And I think we know things around that, like how much guidance fits into, I mean, how could we do that in practice in the school? How much is needed? How does it fit into a visit? How does it fit into a school day? That would be the policy. That would be, I mean, it would be wondering about. That was fascinating.
Right.
I mean, I guess we don't know.
Yeah, you're right. I mean, as Mary put it, it points to kind of this message to providers of just try, because it seems like the guidance that they're giving is meeting, most of the time is meeting their needs. And it's when they don't say something at all, when something doesn't get discussed, that's when the unmet need is right there. So if nothing else, just give it a shot. Just try. But yeah, in terms of how practical that is and how much guidance, how much talking you can do during any given visit, I don't know. I know that there are time constraints, other pressures on provider time.
So can I say something else, and then you can go on to other people? That would raise questions to me about, I framed it in terms of how much can you put into a given visit. But that's the healthcare system as it is right now.
Right.
If we didn't want the additional costs for the ticketed adults, or if we didn't want the additional cost, what would it take?
Yeah.
And that's what I'm pondering.
Yeah.
There's no answer.
Right, but those are good policy questions.
Yeah, the question for me is, I noticed that there seems to be a correlation between depression and anxiety and substance abuse. But could you comment on which is the cause and which is the effect?
I definitely cannot say that from this data. I think we know from other research that those things go hand in hand, and then it can go, and often goes both ways. It's kind of a feedback loop of oftentimes depression and anxiety do lead to substance use, but substance use itself also contributes to depression and anxiety. So it is often, or it's probably a combination of that.
So if I have a patient that has both, what would be the approach you recommend I take to best address that issue? Right? Start with the substance abuse, or do I start with depression?
I think when it comes down to that, it's about your clinical judgment about which thing is the most critical at the time, because you don't want them walking away from you at risk. So which thing you think is going to potentially do the most harm if you're unable to address it and they walk away. So the best I can say. Yeah.
I may, the graduate school response to that institute is both. You don't separate them, you treat both. The cognitive behavioral model for depression, anxiety, and substance use overlap. And so you basically start with just understanding both things. So that's how one way to do that. The other thing you noted was that being female increases your risk. I thought, because that was a risk factor, I thought, and the second one on it, right?
Yeah, let me see here.
Yeah, LGBTQ was below female.
Yeah. Now the effective
Female was always popping up, so what does that mean?
it was included in the model as a control variable because in past analyses there has been a gender effect on having unmet needs for guidance, so we include it just to control for that possible effect.
So males
So
don't.
in this case, no, being female or male does not increase or decrease your likelihood of having unmet needs.
Okay.
Sorry.
Male is not just that.
Yeah.
Okay, so the other one is, you said it was a measure that you think we should be using that screens better for different substances.
Yes.
Do you have that measure?
Well, actually, yeah, as a part of the ESPERT project that I was talking about at the beginning, one of the first things that we did was to develop a tool that's very specific to types of substances used, very specific substances used, to frequency of use, and then even to associated adverse events or behavior problems that coincide with substance use. And it's called the CHESPA. It's something we've implemented in many school-based health centers. And I don't know if you're familiar with the CRAFT. It's a very common screening tool for alcohol and substance use, maybe the most common. It was designed, the CHISPA was designed to follow the craft. So the craft is an initial, like, could there possibly be a problem with substance use? And then if that is positive, which means they answered 2 or more of those affirmatively, then it triggers automatically in the app, it triggers the CHISPA, so that they then go on to answer specific questions. Have you used, any number of these substances, and so on.
How do you spell that?
CHISPA, it's CHISPA. It's an acronym. It stands for, I can never remember, cocaine, heroin,
It stands for the list of substances we worry about, so cocaine, heroin,
IV drugs. Yeah.
We kind of like chispa because it's Spanish for spark. We like them on it.
Yeah.
It's available.
Talk to us afterwards.
Yeah, yeah, definitely. It's definitely correlated, yes. I mean, yeah, and this was something we were just talking about the other day. When you see an effect like that, it is important to note that it's not being lesbian, gay, bisexual, or questioning in and of itself that would make one more likely to use substances, but it is these other associated risk factors. Depression, right? The depression and anxiety.
Yeah, minority stress, discrimination,
right?
Violence,
So that,
stigma, rejection.
can
The
make it.
cumulative impact of those are what's associated with higher rates of substance use, depression, anxiety, and suicide among LGBT population.
Yes. Thank you. You said it better than I could.
Question. This is a very interesting and sometimes troubling data. So from these, can you tell us a successful story? Not some good story. A good story will be what have you used this data to convince others for funding, to change policies in the schools or behaviors? What can you tell us a good story?
Good story. I usually just point out the bad
I'd
stuff.
say a couple of hopeful things.
Yes,
Do
okay.
you mind, Rachel?
Go ahead. You go ahead.
So a couple of, first of all, I should say that we're meeting also with the health department to share some of this data, and hopefully some of them are online listening to this talk. So we absolutely intend to bring these findings back to the state sponsor programs to aware of these findings. But I think there's at least 2 hopeful take-homes for cleanicians, speaking as a pediatrician. I love the fact that this data is very much aligned with other data that shows that patient-centered care leads to better health outcomes. In this case, in terms of half the risk of the saying, I mentioned your guidance. It's really important. There's a wealth of data in the adult population. There's this emerging data in the adolescent population showing that in the adolescent population, when adolescent patients say, my provider listened to me, showed respect for me, explained things in a way that I could understand, and spend enough time with me, just that leads to better outcomes, regardless of topical area. I find that fascinating. It's almost regardless of what problem, you can get better outcomes.
It is, yeah.
That's one of the
risk
things that positive
factors.
message from providers. Secondly, the fact that when providers have a conversation, almost all this data suggests the kids are saying, the adolescents are saying, my needs were met. It really says just have the conversation. And almost always you will do some good. And thirdly, I think, another cool message is it's really a strong endorsement, I think, universal screening. Because screening will lead to these conversations. It will lead to identification of potential problems and probably more likely lead to conversations to better counseling and guidance. So this is, I think, evidence that speaks to or lends support to policies like ESPER, programs like ESPER, universal screening, brief intervention, referral to treatment as a clinical practice. Because when you universally screen for substance use, you universally screen for other kinds of issues like depression, anxiety, you're more likely to address those problems, and you're more likely to meet the adolescent population.
I think that's the question is how do you measure that out? Like reading that identifying its first step maybe your next one has to be these same people. Did that intervention change the substance? Because I think that's what's really important. Because we
Yeah.
need to, I think getting that momentary control is good, but how do we decide that we're doing enough based on a year later?
I completely agree. I just want to comment that if you look at most health issues, most public health issues, or others, you know, like the pyramid, where, you know, there's the high risk folks, but then there's a lot of folks, if you haven't started substance use, you're just starting to. And I think we sometimes forget about the impact we make on the population level of these brief interventions. And, you know, so I think looking at things like adolescents reporting, yeah, my need was not for counseling. In a population level, that can have some impact. But I agree that we need.
So we should look longitude.
Yeah.
Wonderful work. Congratulations.
Thank you.
Oh, oh, that's right. Oh, good.